Hello, and welcome to Quick Look Critical Care. This is the first part of our series, and it's called Quick Look Signs of Decompensation. So, in the introduction, I just want to remind you that proper management of all critical patients really requires that we identify this early and that we identify what the problem is and the problem that might kill the patient. So sometimes patients present with a myriad of problems, but we must identify the one that might kill the patient, and that we're going to take and perform quick measures to intervene, and that will be based on our evidence, our science, and our communication with all of our provider partners. It's always important to remember that patients at high risk for actual or potential life-threatening health problems, particularly sepsis and COVID-19, are very unstable. They have complicated issues involving the kidney and the lung and the heart and the brain, and they are highly vulnerable. So just small adjustments in fluids, vasopressors, situations, position may actually put them more at risk. Now, what we want to remind ourselves is that everything we do is about assuring adequacy of perfusion, and our goals will always be how to detect that perfusion is poor or that perfusion is too much perfusion. Those goals help us to determine how to titrate our therapy to specific hemodynamic endpoints as well as organ issues. And we want to be able to differentiate this among very major issues and various organ system dysfunctions. So we're going to talk a lot about hemodynamic monitoring, both in the abstract and in the reality, and consider that hemodynamic monitoring is physiologically based and always has an end goal. Now, when we talk about identifying patients at risk of severe illness or deterioration, it makes perfect sense that at the first sign that we have a patient who is at risk, if you look at this correlate, which is just a simple cartoon and not really meant to be funny, but you can see that at the first presentation in the early time indicator, it's bad. But as time goes on, badness increases. What that means is the longer your patient is presenting with signs of deterioration, the worse they are and the harder it will be to retrieve them from a poor outcome. So our idea is to try to maximize the likelihood of easier management with simple interventions, fluid, vasopressors, position therapy, and to try to prevent further deterioration. That allows us some time to investigate and treat the patient. And we can apply this strategy in just about everything we do: hyperglycemia, hypoglycemia, CRRT, and all hemodynamic cases, to actually identify the problem early, to treat the problem to prevent further deterioration, and allow ourselves some time to investigate and manage what's occurring. That helps us to build a chain of safety. A safety chain actually takes the measurement of our observations and documentation and bringing that together and recognizing deterioration, allowing us to have the science behind creating an alert to our providers and communicating appropriately, responding efficiently, intervening, and then reassessing. So sometimes we might say, this patient is very anxious. He's going to extubate himself. I had to tie him down. I'm so concerned about this patient. I need to increase his sedation, all of which may be true, but it wasn't necessarily prevented or presented in a scientific manner. So if we are measuring our observations, our patient's respiratory rate has gone up, his heart rate has gone up, and he is competitive with the ventilator. We're concerned that we need to increase sedation in order to achieve better ventilation and oxygenation. And in that communication, we actually build what our goal is and what the problem is, identifying it early before the patient extubates himself or creates further damage for his lungs. When patients decompensate, it's really important to remember that that doesn't, in general, just happen. Typically, patients present with deteriorating signs for 2 to 6 hours prior to respiratory and cardiac arrest, prior to requirements to intubate. 84% of cardiac arrests are preceded by deterioration of both respiratory and mental function, and 66% of cardiac arrests have documented deterioration 6 hours pre-arrest. Now, what does that mean to us? It means that we need to have a small envelope of suspicion. When we are evaluating patients, every time we look at them, we consider what they presented with before and what they're presenting with now, and we're going to categorize those into some simple strategies for decompensation. First, starting with the airway and respiratory system. So on your right-hand side of the slide, it says A and B means airway and breathing, of course. But what I want us to note, most importantly, is that have we seen that the patient is breathing more rapidly? Are we seeing different muscle groups being used in order to draw air in? And what is the pattern of breathing? And I bring that all together to say one thing that is the most important issue in evaluating a patient pre-deterioration, and that is an increasing respiratory rate. An increasing respiratory rate is the constant across all age groups in the continuum of prediction of deterioration. So we want to remind ourselves that the pulse oximeter is going to fall somewhere between 2 and 3 minutes after the patient has deteriorated. And it's a wonderful tool to give us some support, but more importantly, the respiratory rate, the depth, and the pattern of breathing will give us information about patient deterioration. So I love to remind everyone the most common sign of deterioration is the rapid respiratory rate. Now, we're always going to assume that that's a compensatory mechanism for metabolic acidosis until we prove otherwise. Now, what does that mean? It means when I have an increase of acid in the blood, acid is carried in two ways: hydrogen ion, which is the metabolic acid, and carbon dioxide, which is the respiratory acid. Both are acid productions from the cell, but CO2 can actually be removed by the lung. So when we actually have a high presence of acid, respiratory rate will increase and respiratory depth will increase in order to mobilize that carbon dioxide. Now, if we're at the bedside with the patient who is intubated, who has SIMV, and prior to now, SIMV being a spontaneous efforts generating mechanical ventilation, and his rate was 19 when I was in his room 2 hours ago, and now it's 28. He has an increased respiratory effort. Now, of course, I'm going to look at the mechanics of breathing. Is there fluid in the tubing? Is the ventilator set correctly? But in addition to that, I have to actually look at, is my patient agitated? And why is he breathing so fast? And one of the most important things is before we reach for sedation, we should know why the patient is breathing rapidly. We don't want to suppress his breathing. We'd like to support it until we can uncover what the problem is. So uncovering the why of a rapid respiratory rate is quintessential to good nursing care in an acute and critical patient. And throughout our series, we're going to talk about all of the components of evaluating an appropriate respiratory rate and the whys and wherefores. So remember, the rapid respiratory rate, RRR, is assumed to be compensatory for metabolic acidosis until proven otherwise. Now, there are some simple strategies that we can apply here that we're going to talk about more later. What I want you to remember is the basic rule of 20. Total serum CO2, which is on your chemistry profile, if it's lower than 20, that indicates metabolic acidosis, and the rapid respiratory rate should be assumed to be compensatory for that. If the total serum CO2 on your chemistry panel is less than 20 and you have a rapid respiratory rate, you believe that's compensatory for metabolic acidosis. If the anion gap on your chemistry profile is greater than 20, that indicates metabolic acidosis. And so again, assuming that chemistry rule of 20, total serum CO2 and anion gap, total serum CO2 below 20 and the anion gap above 20, that tells us we have metabolic acidosis. Now, if we have an ABG, the most important thing we're going to look at on our ABG is the opposer of metabolic acid, which is your serum bicarb. And at our hospital, we measure that most significantly in context as the base deficit. So a base that is in deficit means an acid that is in excess. A bicarb that is down means an acid that is up. So we always bring that together when we're evaluating our patient in conjunction with rapid respiratory rate. Now what that means is you don't just assume that when you have a rapid respiratory rate you should sedate the patient. You need to investigate what the cause is. But of course, you must protect the patient. If he's hyperagitated, hypervigilant, moving around, of course you have to protect the patient, but you still have a responsibility to uncover the problem. And when we uncover the problem, we find better methods to improve our patient's outcome. So we talk about monitoring oxygenation with arterial blood gas analysis. That will give us our PaO2 and our SaO2. PaO2 is the oxygen dissolved in the blood that can be used by the cells, and the SaO2 is the oxygen that's being transported by the hemoglobin. It's bound to the hemoglobin, so not usable until it dissolves. So I always like to look at the PaO2, and I always like to look at the SaO2 to tell me what the state of oxygen availability is. At the bedside, I also use the pulse oximeter, which is a fair step from SaO2. It's a very primitive relative, and it just gives me a general idea about the amount of oxygen that is bound to hemoglobin. It's a good tool at the bedside that indicates whether or not I'm having problems, but I'd like you to remember your pulse oximetry reading does not go down for 2 to 3 minutes after your patient is actually deteriorating. And then we also can think about venous blood gas and mixed venous blood gas samples. That's beyond this discussion, but we will review that later. All right, so next we talk about circulation. Circulation, changes in trends, changes in heart rate, changes in blood pressure, changes in the temperature of the distal extremities and the pulses of the distal extremities. But very importantly, I'd like you to remember that evidence of decreased perfusion can be evaluated by mental status changes. So I was awake and alert, and now I'm a little drowsy. I was a little drowsy, and now I'm lethargic. And when you wake me up, I don't really understand the content of our communication. More on that in just a moment. Also, remember, for most hypoperfusion states, your skin temperature, particularly at the distal extremities, will become cool. So cool hands and cool feet often mean I have a decreased perfusion. Not always, but generally. And I'm going to correlate that to a reduction in your urine output, remembering that urine output measurements are hourly, and that if we look at hourly measurements over a period of time, maybe 6 hours, we divide that total by 6 to tell us the average urine output, and then we divide that urine output by your body, by your weight, in order to tell us about how much urine per kilogram per hour you are making. So we bring that back to central and peripheral pulses, which will give us an idea about your blood flow dynamics. So many ways for us to monitor your circulation, certainly by palpating your pressures, by auscultating your heart sounds, by looking at your EKG. Is it bradycardic? Is it tachycardic? Do you have dysrhythmia? By evaluating your blood pressure, systolic pressure, of course, reflecting the response of the arteries to ventricular ejection, and diastolic pressure representing the way the blood flows through the vessels and the vascular tone. Now we can use automatic blood pressure oscillometric devices. That's what our basic automatic blood pressure monitoring is. If we lose that ability to read that pressure, we can also use Doppler to actually detect your blood flow dynamics and look for your pulses. And of course, we can always consider the placement of an arterial catheter to help us monitor your blood flow dynamics. Those will come back to us later as we talk about invasive hemodynamic monitoring. The second most common sign of illness, remember the first is that rapid respiratory rate, but the second is tachycardia. So we're always going to follow the heart rate. And by the way, persistent tachycardia is never normal. Persistent tachycardia is always telling us about compensation. So when we think about that, we correlate that to another rhythm that frequently tells us about decompensation, and that would be new onset atrial fibrillation. So when we think of this, we correlate those two in terms of circulation. New onset sustained tachycardia, new onset atrial fibrillation, and of course, what we all love. We love it so much we measure it in multiple ways, and that would be your blood pressure. Now, one thing for us to remember about blood pressure is, first, it requires blood flow in order to be measured. You must have blood flow to measure a blood pressure. But in addition to that, you also must have vascular tone. So of course, you can completely appreciate that the two ways that we treat circulation and blood pressure is we try to improve your blood flow with volume and inotrope, and we try to improve your vascular tone with vasopressors. What we're trying to do is reach a balance where you have adequate blood flow, but you maintain a blood pressure that is adequate to keep your blood vessels open and perfused. So, always like to remind you with a little word about blood pressure. Blood pressure is something that changes late in a deterioration process. By the time your patient drops his blood pressure, you may have already missed the early signals of decompensation. So we don't want to do that. We're all trying to do the best we can for our patients. Now, you all know how to measure blood pressure, and in general, we do intermittent blood pressure monitoring with our Dynamap, which is oscillation. But intermittent blood pressure monitoring takes a snapshot in time. It's not nearly as good as a continuous blood pressure monitor. So at Grady, continuous blood pressure monitoring is performed with an arterial line, and we can also perform it non-invasively using a pulsatile clamp. That's called ClearSight, that allows us to continuously monitor your blood pressure even though we haven't placed an arterial line. So, very important. All you need is an A-line connected to your bedside monitor to continuously monitor blood pressure, but you must have an A-line, which is invasive. You can also monitor blood pressure with a finger clamp. It's called a volume clamp that inflates and deflates continuously, and that portrays a continuous blood pressure non-invasively. So for us right now, we have three basic, simple ways: arterial line, finger pulse technology with the ClearSight, and our Dynamap. Those are the three ways that we use currently at Grady Hospital to measure your blood pressure. It's really important to remember that the arterial line actually gives us an indicator of blood flow, whereas oscillation gives us an idea of vascular tone in response to blood flow. So it's more about the pressure rather than the blood flow. And then we talk a lot about mean arterial pressure, which is typically how your physicians are writing orders for treatment. Give volume, give vasopressor, give inotrope, based on the mean arterial pressure. The normal mean arterial pressure is relative to each patient because it's the arterial pressure required to keep the arteries perfused and the small microvessels at the organs perfused. But typically, our orders are written not to evaluate all the organs' perfusion, but our orders are written generally to drive the mean arterial pressure between 65 and 85. So typically we will be concerned when the mean arterial pressure is less than 65 and when it's above 85. And just that nice window, 65 to 85, typically is results in good perfusion and maintenance of arterial blood flow. Now, of course, persons who live as hypotensives or hypertensives are going to have a shift to the right or the left for that mean arterial pressure. So what that, of course, means is you must always, always know your patient's history. That will help us in determining where we want to set their mean arterial pressure and how we're going to drive that with therapeutic intervention. All right, now the big one, which is acute mental status change. That's number 3. Number 3, acute mental status change. Now, we don't have a very clear definition of this, because most of us use Glasgow Coma Scale, and the word in Coma Scale is coma, right? But what we want to remind ourselves is that mental status has 2 parts. Can you wake up and have some response? Open your eyes, squeeze my hands, wiggle your toes? That's really arousal. And that's almost brainstem function. It's pretty low level. It's a little higher than the brainstem, but it's pretty low level. What's more important is awareness. Awareness is the ability for you to actually perceive your environment and to understand, to hear and understand, to hear and perform, to hear and remember and perform. That's a much higher level of mental status. Now, I want to remind you, one of the things we talk a lot about with mental status is delirium. And delirium is something that we see a lot in patients who are intubated on ventilators, who've received a lot of sedation or pain medication. Oftentimes what they have in this state is a decreased attention span and confusion that comes and goes. So at 9 o'clock, I go in the room, I ask some questions about your attention span, your ability to perform, and whether or not you're confused, and you look gorgeous. 6 hours later, I go back in the room and it's completely different. And that's because mental status changes and delirium wax and wane. And so depending on the situation at that time, do I have good blood flow? Do I have good kidney clearance? What else is happening? I may have a patient who in the morning is completely clear, aware, perceiving, understanding, and by the afternoon, that's no longer true. So first and foremost, we have to be accepting that mental status change is a fluid process. It does not always stay the same, hence we need to always be able to evaluate. Now, when we think about abnormalities of mental function, this is really just simplified. This is not intense. This is just simplified. Is first of all consciousness. Can you wake up? And that's kind of the lower level of GCS. And then awareness and cognition are higher levels. And most of the time we can measure higher level cognition with a mini mental status exam. But that typically takes some training. It's a fairly high way of evaluating our patients. And in general, we're not applying that at the bedside. But what we can apply at the bedside is the confusion assessment method, CAM-ICU. Now, most of the time, people are thinking about CAM-ICU to measure transient delirium, but the CAM-ICU also helps you to evaluate whether or not your patient has altered mental status. So it really needs to be an integral part of your evaluation every time you're evaluating neurologic status. Remember, what that does is it, first of all, tells us if you accurately perceive your environment. That's your orientation. Are you able to understand what I say, process that data, and generate return data that's meaningful? One of the ways that we do that is we say to individuals, what does the Rolling Stone Gather No Moss mean? What does that mean? Well, I might not have ever heard that before, and I might not know what it means. But if I have heard it before, I'm going to say, well, it means if you keep moving, you don't get static, and nothing grows on you because you're always moving along. So you can appreciate that there was a reasonable interpretation of that statement. Memory is basically saying to someone, I want you to hold up 2 fingers and then you put your hand behind your back and you say, how many fingers did I ask you to hold? Don't keep your fingers up there because they can just mimic. How many fingers did I ask you to hold up? You asked me to hold 2. Can you show me on the other hand? Yes, I can. So storing the information, retrieving it, and performing all aspects of mental status. So this is somewhat tiny, but you can see it anywhere on any ICU. This is the CAM ICU document. The CAM ICU document actually helps us to evaluate environmental perception in someone who is awake. So somebody who has a RASS score, a Richmond Agitation Sedation score of -1 or 0. If you're awake, we can actually evaluate these things. If we can wake you up, we can evaluate these things. And we'll ask you a series of questions to see if you remember and if you can retrieve information and if you can perform. CAM is relatively simple, but it does require some time to evaluate at the bedside. But this will help you to understand where your patient is as he goes along throughout his day, not only as it relates to delirium, but just as it relates to mini mental status changes. So the real idea here is that when we notice small changes in many systems, your heart rate went up mildly, your respiratory rate went up mildly, and you've had a small change in your level of consciousness. That helps me to identify you're a patient at risk. I've got my eyes on you. I got my eagle eyes on you, and I'm communicating effectively with my provider colleagues. Big changes in any one. My heart rate was 80, now it's 150. Well, that tells you your patient is at risk, but it's a much later predictor because you probably had evidence before now. My blood pressure was 100 and now it's 40. That's a big change in one measurement, but there was probably signs and symptoms prior to that would have let me know that if I had done some small steps, I could have prevented that rapid evolution. So I always say it's important to pay attention to those small multi-changes. Be afraid with one big change because that means we missed the earlier signs and our patient has already deteriorated. He's already decompensating. So remember, our goal is to look at the 3 basic perspectives: airway breathing, circulation, mental status, and to use those tools to help us appreciate caution, patient at risk. Salient points so far: early recognition of subtle changes should be considered and discussed. Persistent tachycardia is always a cause for concern, as is rapid respiratory rate on or off the ventilator, because it's likely to be compensatory for metabolic acidosis. Any changes in content, meaning cerebral content, may indicate decreased cerebral blood flow or alterations in brain chemistry. And by the way, if you're not looking for it, you can miss it. Please keep your patients safe, keep your eyes wide open, and your communication channels current. Thank you.